Hello and welcome to what promises to be another very exciting episode of the AABIP podcast. I am honored to be in the presence of Dr. Samira Shojaee. Dr. Shojaee is the program director for the Interventional Pulmonary Fellowship Program at VCU in Richmond, Virginia, and she is an associate professor there. Dr. Shojaee, thank you so much for your time today.
Udit, thank you for your time and thank you so much for inviting me.
So today we'll be pricking Dr. Shojaee's big brains on the topic of diagnosis and management of chylothoraces, and we'll probably focus a little more on the management aspect. Dr. Shojaee, any relevant conflicts of interest with this topic?
I have nothing related to this topic that is a conflict.
Awesome. All right, so let's get started then. So let's start with the diagnosis of chylothoraces. So in the appropriate clinical setting, is the gross appearance of pleural fluid being milky sufficient to diagnose a chylothorax?
So that's a great question. And no, it's not. There is actually a good, probably up to half of the patients may not even have a milky pleural effusion. It may be cloudy. It may not even be cloudy at all. It has to do very much with the patient's diet. And what I usually have in the back of my mind, I know a lot of people that measure and check cholesterol and triglycerides very routinely in their pleural fluid analysis, especially the first fluorocentesis. Unless I suspect chylothorax upfront with it, I may not necessarily get the triglyceride and cholesterol routinely. But if I get the results and they don't make sense and I don't have a diagnosis for the patient, then I will definitely, and I have to do the drainage again, then I will definitely send for triglycerides and consider chylothorax, even if the pleural fluid was not cloudy at all.
So the traditional threshold we use for triglyceride level is greater than 110. So let's say I have a patient with esophageal cancer. He hasn't been eating in a long time, and he has this pleural effusion. I suspect it could be a chylothorax. I send a triglyceride level. It comes back at 80. Is there any utility in checking lipoprotein electrophoresis, or is this 50 to 110 threshold sufficient in your mind?
I would still check. I love your example. It's perfect. Esophageal cancer, not eating. It's the right scenario. Unfortunately, these patients are malnourished and aren't eating. But I would send lipoprotein analysis just to verify and see chylomicron in the pleural fluid, just to make sure that I give it a definitive diagnosis. The triglyceride levels aren't, by the way, always meeting our cutoff criteria. Sometimes triglycerides may be lower, and the patient could still have chylomicrons in the pleural space. So I think if there's any doubt, I usually do check to verify. Not if the triglycerides are already above threshold, but if they aren't.
So we have a patient with a chylothorax, and we're going to proceed with discussing the management. But as an interventional pulmonologist, is there any utility in confirming the site of leak with a lymphangiogram or lymphoscintigraphy? Or is this something that we would, leave to IR or surgery if one of those approaches are considered down the line?
So I would return a question to you with it. I would say, do we know what's the cause of the chylothorax? Because it really depends on whether the cause is traumatic or non-traumatic. Most cases, I think you would still benefit from knowing where the fluid is coming from, the chyle is leaking from, but it's not always helpful. First of all, you can't always find it. Secondly, in patients who, let's say if a patient has metastatic lymphoma, end stage, very sick, I wouldn't send the patient to have a lymphangiogram. But if they have concern about a possible traumatic chylothorax or post-surgical, let's say a patient had a pneumonectomy or a lobectomy or another form of surgical procedure, then I may approach that differently. So it really depends on, I think it depends on the etiology, or at least narrowing down that differential diagnosis so I could get a sense of what possible etiologies are there.
Okay. So then let's
Does that answer your question?
Yes, it does. Yeah. So, and I'll come back to that a little bit later. So let's just jump into the management. And of course, the way you manage a chylothorax would, I guess, largely differ on the etiology. And we can broadly classify this, I guess, as traumatic chylothoraces, which include the iatrogenic group of post-esophagectomy, post-pulmonary resection, and then the non-traumatic group, which includes multiple etiologies.
Yeah.
So let's say I have a patient with a non-traumatic chylothorax. Let's talk about the malignant chylothorax, just because probably that's the most common one we'll encounter. Does everybody get conservative management with medications and diet, and how do you approach this?
Not everybody does, as is the case with a lot of the questions. It depends is always a good answer, but I'll elaborate. So it depends on the patient's symptomatology, and is this the first time that you're getting a chylothorax? So if I have a patient come in for the very first time, and they have a chylothorax, and I diagnose it up front, and I follow up with the patient, and the fluid doesn't come back, I may not really do anything else besides watching the patient as they're going through their treatment. There's a good chance that my fluid analysis happened at the same time where the patient was having mediastinal exploration and was diagnosed with lymphoma and already got radiation. And by the time they may be due for a new thoracentesis, their chylothorax has already improved following radiation. So it really depends. And so to address your question in terms of medical therapy, if you consider, let's say, radiation therapy and chemotherapy under that umbrella, then I would say those patients would benefit from getting some form of less conservative, less surgical treatment before you escalate. But at the same time, if a patient comes in, has a large volume of fluid come out of their chest, and I, let's say, drain 2.5 liters, it's all chyle. This has actually happened before, where I would drain the fluid and I would test it, and it would clearly show that it's a chylous effusion. And then the patient's chest is filled up again in 3 days. Then I'm concerned. Just knowing that you flow about 2.5 liter of chyle in your thoracic duct per day. If I drain 2.5 liter every day or every other day, then we have a problem. The patient is very likely to become very immunosuppressed and very sick and malnourished very, very quickly. So then I may be a little bit more vigilant about getting the patient through a more invasive procedure, because I think the progression of disease is very, very fast.
So let me clarify. So to diagnose a chylothorax, you need a thoracentesis. So your thoracentesis initially is diagnostic and therapeutic, and you drain the space. If there is no signs of early recurrence, that may be sufficient, is what you're saying, right?
That's correct.
But if it does recur, then you go into doing something else.
It depends on how fast it recurs.
So, and you mentioned a very dramatic threshold of 2.5 liters a day. So in that situation, I'm sure that a patient needs some sort of invasive intervention, right? Whether it's IR or surgery, if you're really pouring out chyle.
Absolutely.
So let's say somebody has 500 cc's a day reaccumulating. You've placed a chest tube. You know about 500 cc a day is coming out consistently. Are these the patients that you would initially try first on conservative management?
Yes, I think that, yes. So thanks for clarifying. That's a good example. It's, chylothorax isn't very common, but if you have a malignant chylothorax, that's probably a more common presentation. I would still start with the treatments that you would do for a patient who even has a traumatic chylothorax. I would change the diet. I would focus on decreasing the amount of fat or the certain type of fat, especially for some of these patients, they're already malnourished. So they may benefit from, I would ask a dietitian to see them. They may just replace their fat with medium chain fatty acids, for example. And so that could significantly change things. Octreotide sometimes helps. I've actually had a patient get started on octreotide and change their diet and go through chemo and radiation with the hope that they would respond. And if they don't, and they continue to have fairly moderate size but consistent volume of fluid, then I would move to more invasive procedure. But I would probably start from with a more conservative medical management first.
And what is your threshold to use octreotide, or do you always use it in patients who have recurrent chylothoraces that you are managing conservatively?
I've actually only used it in one patient in conjunction and discussion with, and I should have probably said this way up front, in a multidisciplinary fashion. So if it's malignant, then I always talk to an oncologist, and with the agreement of the oncologist and the patient, knowing that they're not always going to respond to treatment, then I would start octreotide. If diet didn't help, if the fluid recurrence is consistent, if drainage is required, let's say once every 2 weeks of liter fluid or something like that. And then we would discuss, let's start you on octreotide and see if you have any benefit. But that's in a setting where a patient also has altered their diet and is still going through chemoradiation.
Okay, so you have a scenario now where there's a patient who's either dumping a large amount of fluid a day or has failed conservative management and is still putting out a moderate amount of fluid. You decide to proceed with something definitive, so which is either surgery with thoracic duct ligation or something else, or IR for thoracic duct embolization or disruption. You mentioned MDD. So is MDD always a part of the next step, or do you usually try to consult surgery first, and then if doesn't work out, then maybe IR is the second option?
Is this so can I clarify? We're still talking about the malignant?
I'm talking about a patient who you think would be a candidate for both of these. I'm not talking about a traumatic chylothorax, let's say a post-op chylothorax or penetrating trauma chylothorax.
Okay, because I was going to say, if I have a malignant case, I would probably not rush to surgery if they've already failed chemo and radiation. That's usually a sicker patient that I want to be a little bit more, less as little invasive as I can be. Post-surgical, if the volume of fluid, as you're saying, is large, and this actually just happened 2 months ago. Patient with blunt trauma came to the trauma service and had a chylothorax. And so what we ended up doing was change the diet very quickly. The patient quickly became NPO because they were dumping large volumes of fluid. They already had a chest tube in place placed on the scene during the trauma, and they were putting a whole lot of fluid out. I actually quickly sent the patient to IR. For thoracic duct ligation. Surgery certainly is a possibility.
Let me clarify, IR for embolization, right?
I'm sorry, IR for embolization. I apologize. Yes, and lymphangiography. So the patient would go and would get a diagnostic, so find source of leak and then treatment at the same time. Ironically, as they had started to fast, their chylothorax production completely stopped. So if this patient did not have as much volume of fluid coming out regularly, I would have probably not sent them for IR. What I would do is just wait. And many of these patients get better by time. By time, I mean you need to be very, very cautious and careful. If you just kind of wait until it's time to pull the trigger, the patient may become very malnourished. But if they're steadily getting better and the volume of chyle is decreasing, you may not even have to send them for a surgical or IR procedure.
So you raised two very interesting points. So you seem to be talking about surgical intervention and interventional radiology in the same scope. So if I were to clarify this, it's probably true in those setups where IR is advanced in the sense that centers of expertise, right? I mean, I don't think doing a thoracic duct embolization is everyone's cup of tea. Am I correct in saying that?
Probably, yeah.
Okay, so either surgery or IR, depending on what setup you're in, MDD is the key. Would that be fair to say?
That's fair to say. If I had both of those, I would send the patient to IR. Just
because it's less invasive.
Yes.
As the first option.
Yes, as a first option, it's less invasive, and it also it has the same level of success rate.
Would you say it has the same level of success in, let's say, a malignant chylothorax as opposed to a
no, talking about
only traumatic chylothorax?
Yes.
Perfect. That makes sense.
Yeah.
So the second interesting thing you mentioned is that, weight over time, things may change. So let's say you have a malignant chylothorax and the output is somewhere in the 300-400 cc a day range. Is this where, if you want to wait for treatment to take effect, you can place an IPC and, follow up the patient closely, say in a couple of weeks, and then make a more informed decision?
So let me clarify what I said earlier. So what I mentioned, sometimes with a little bit of time, things can improve. I was talking strictly about traumatic chylothoraces, because they do not infrequently get better with change of diet, sometimes becoming completely NPO just for a few days. But for malignancy, I personally have not had the same luck as with traumatic induced chylothorax. So in malignancy, I think it would be different. Your question about a tunneled pleural catheter. Yes, so there is very little evidence, and I try to look at that and the overall purpose of the tunneled pleural catheter, or any catheter, if I'm trying to manage this. Is the patient short of breath? Can I ask you?
We're talking about somebody, how much they're putting out, right? So let's say they already have a chest tube. And
they already have a chest tube.
They already have a chest tube. You know how much output they have on a daily basis.
Okay. Do they have a peritoneal chylothorax chyle effusion as well?
For the sake of the discussion, no chylosocites.
Okay. So one possible option is to just put a pleuroperitoneal shunt. Mm-hmm. If they already have chylous effusion in their abdomen, then that's probably not useful. But if they don't, would I put a tunnel pleural catheter? I probably would in a patient who is very dependent on the drainage, who is very short of breath, but who's very end stage, because you're basically draining all of the T lymphocytes and most of the nutritious material from that fluid. And so it's I would be concerned about putting a tunnel pleural catheter unless it is symptom-guided drainage, not frequent drainage, let's say once every week drainage or something like that. If your concern is about, there's not a lot of fluid in the chest, but it's there, and the patient's already short of breath, but they're not benefiting that much about the fluid, wouldn't be too concerned about the fluid being in there, just because chyle generally is not inflammatory. Although in the case of malignancy, obviously the patient could have other reasons for having septations and inflammation inside their chest. But I would only put it for the sake of symptomatic management and as a very, very last resort.
So I'm going to clarify this again with a scenario that I've had a couple of times this month. So new diagnosis of lymphoma, patient is otherwise pretty healthy, and they had a chest tube placed because the chylous effusion recurred very quickly. On a daily basis, they were putting out 200 to 300 cc's of fluid. So they really could not be discharged, but they hadn't started treatment yet. So in these scenarios where you want to sort of symptom palliate a patient, but allow them to leave the hospital, are you saying that you prefer some sort of pleuroperitoneal shunt over a tunnel pleural catheter, or do you just sort of manage these patients as an inpatient for a longer time and try to get inpatient chemoradiation or something started?
Yeah, 200 to 300 a day. I would remove the tunnel pleural. I would remove the chest tube and send the patient home.
Okay, and then see them back in a week or so? Or
I would have a follow-up with them in a week or 2 weeks. They will go through their chemoradiation. And if they come back in a week and they have, let's say, a liter of fluid in there, I would drain it then. And I would assess very closely to see how frequently do I need to drain this, and are they responding to chemoradiation? If it's a new diagnosis, based on what you were saying, if it's only chyle, if it's infection, it's different. But if it's chyle and it's 200 cc of otherwise precious fluid, I would probably I would probably not drain it. I would just remove the chest drain and close up the space and send the patient home. If the volume was larger, then I would probably try with a pleuroperitoneal shunt as opposed to a tunnel pleural catheter.
With the caveat that there should be no chylous ascites.
That is correct, yes.
Okay. And just to clarify for our listeners, I guess that's because once the fluid shifts into the abdomen, the abdominal lymphatics, the stomata and the diaphragm that are supposed to absorb the chyle, they are not overwhelmed. So if there's no chylous ascites, they would suffice in draining all the fluid, right?
Yes, exactly. And you would hope that as much as that chylous effusion that is possible could be reabsorbed into the circulation. That's why I wouldn't it's not that I wouldn't put a tunnel pleural catheter because I would be particularly worried about infection or something else. I would mostly just want to keep the fluid in if possible.
Awesome. So this has been absolutely great. This is a topic where there's very little guidance available. There's no good studies available. Most of the data is retrospective. That's right. Practice varies drastically. That's correct. From physician to physician, setup to setup, and this independent of resource availability, I feel. So your opinions are absolutely great. Thank you so much, Samira, for that.
Thank you.
Absolutely. If you don't mind, just for the listeners, if we can just summarize, the management aspect one more time. So I'm going to say what I think you said and just correct me if I'm saying something incorrect.
Sure.
So traumatic chylothoraces, you can take a watch and wait approach, manage conservatively because the output is likely to decrease. If it doesn't, then you proceed to surgery or IR. But initial wait and watch is fine with conservative management, correct?
Can I add just one thing that you got to be very cautious about your wait and watch. If the wait and watch is 2 weeks, that's too long. It depends on the volume of fluid drained. If it's 2.5 liters every day for 4 days, that's already long. But if it's smaller amount of fluid and it becomes less and less every day, and the patient is supported in terms of nutrition in some other form, then yes, that's completely correct.
So low output, short duration, wait and watch. High output, long duration, proceed with something else.
Exactly.
And in the non-traumatic chylothoraces, obviously you want to get etiology-driven treatment started as soon as possible. You go for conservative management. If your etiology-directed treatment is going to take time, in your setup, you prefer some sort of palliation with a shunt, if at all needed, rather than an IPC. Your threshold to pace an IPC is very high.
Yes.
Really, you're talking about an end-stage patient where it's really, really palliative, right?
Yes.
And you cannot shunt that patient.
Exactly. And IR is not an option.
And when they have this intermediate output of about 200-300, you basically wait and watch, let the fluid reaccumulate. If they get short of breath, you'd rather do intermittent thoracentesis and try to buy them more time till their treatment kicks in, correct?
Yes, but let's add another scenario to this. So if a patient is needing thoracentesis every 2 weeks for 3 months, then obviously that's not a useful scenario either. Then in that case, I would look into other options such as pleuroperitoneal shunt or IR management. And if they're still not responding, if this is lymphoma, then their chance of responding to radiation is fairly high. It's more than 50%. But if it isn't, and they're not responding to radiation or chemo, and there's still fluid and it's large volume and nothing else is helping, then I would again put a tunnel pleural catheter in that patient for palliation of their symptoms.
Perfect. I think this is very clear. Is there anything else you would want to touch upon before we end the podcast?
No, I think these are all great questions, and I think it's also a very stimulating topic because, like you said, there is not a lot. One more thing you mentioned in terms of watch and wait. I just want to emphasize this one more time. I have seen a patient with chylothorax go through that watch and wait process, and then the decision to let's do something like IR. But at that point, the patient is too sick and too malnourished and too and infected with sepsis and everything because of immunosuppression. So that weight portion has to be it has to be in quotation. So a very careful decision in terms of how long you want to wait. You don't want to wait until the patient is so sick that they can't really tolerate anything else.
Mm-hmm. And I think we've been very careful with not, specifying
how long
numbers, right? Yeah, because 1 week, 2 week, 500 cc's, 1,000 cc's a day, all these numbers that are quoted in different studies. I think it's so scenario specific. That just saying that 500 cc's a day is too much. 600 is way too much, or 400 is not. I think that makes it very confusing.
Yes, exactly. And since it is scenario and patient specific, I personally, chylothorax is not a very, very common occurrence. And I like to, depending on the etiology, I like to approach it in a multidisciplinary fashion. So either with a surgeon or with an interventional radiologist, with a oncologists. It's always helpful to have other people on board who know about what's going on with the patient.
And for our listeners, if your MDD doesn't suffice, shoot Dr. Shojaee an email. All right. Thank you so much, Samira. This has been fantastic.
Thank you so much, Judith. Thank you.